Um, I will, I wanted to kind of define what has traditionally been defined as survivorship, talk a little bit about from like the doctor standpoint, the medical exams, the tests and the studies, just so that everybody is aware of, where from a medical standpoint, the things that are kind of check boxes that are done to be able to detect cancer if it ever comes back and things like that, just from a medical understanding, and talk about some of these guidelines, and then really move to Thrivership and focus a little bit about what that means to everyone on the call, and to have that really be interactive and for folks to share and have reflections that can be shared with everybody here, and things to take home and thoughts to take home after the call. Defining survivorship. So some of these slides I got, or some of these statements I just pulled off the internet through the National Comprehensive Cancer Network, NCCN, guidelines for patients, because those are kind of the guidelines that drive how we care for people with cancer diagnoses in the United States, and influence greatly how we care for people abroad as well. They define cancer survivors as people living with cancer and those free of cancer. Survivorship starts at the time of cancer diagnosis and continues throughout life. And survivorship care includes recovering from cancer and promoting health, which are all fine and nice. And I have thoughts and some notes that we'll get into. Okay, so there are some standards. So this is like what we as physicians and everyone with a cancer diagnosis are expected to kind of do. This is mostly like after, let's say, a treatment plan has been completed, and that treatment plan including surgery, chemotherapy, radiation therapy, and the kind of the completion of upfront. So when folks are on even immunotherapy, we start kind of really thinking about these things, right? Routine testing for the return of cancer called surveillance, and new cancers screening. So like continuing breast cancer and colon cancer screening after one has completed therapies. Routine testing for late and long-term effects of cancer and treatment, prevention of harmful effects of cancer and treatment, management of cancer-related challenges, including the referral to specialists. So this would be like sexual health, significant fatigue, menopause symptoms, neuropathy symptoms, and seeing like physical medicine and rehabilitation specialists. Coordination of care between providers, which anyone who's received healthcare in America knows that this is actually a really tall ask, to ask doctors to be coordinated with one another, and then planning for ongoing survivorship care. So those are kind of the standards that we've set on kind of survivorship and how we are thinking about the care of folks after they complete some of their upfront treatment. Okay, so I'm going to spend a little bit of time just sharing kind of what's out there, what kind of should be happening, and so just for folks to have increased like education and awareness of what the medical expectations are for managing folks again after that upfront treatment and care. So long story short, from an endometrial cancer standpoint, this is the table that was included in our guidelines that came out in February of this year for how to manage and monitor people after they have completed their upfront treatments. And upfront treatment can be anywhere from all I needed was a surgery, and I'm considered that was all I needed cured, to I needed a surgery followed by chemotherapy, plus minus maybe some radiation therapy, and now I'm on immunotherapy for an extended period of time, right? So there's the whole gamut of kind of treatment management, and oncology communities are a little bit split with this. We don't have amazing ways to monitor for cancer return, and we on the right side of the screen, the 2017 Society for GYN Oncology guidelines, SGO guidelines, the recommendation was for having, 6 to 8 or 14 clinical exams over the first couple of years after diagnosis, and then no recommendation for vaginal cytology, which is basically looking at cells in the vaginal secretions, almost like a pap smear. Only imaging, only doing CT scans if patients had like symptoms like new bloating or new bleeding or new pain, and then no real recommendations for getting blood tests. Removing there's a lot of kind of question and concern about that. So what's outlined in the red box is a clinical trial that was done to compare, and this is done out of Europe, in fact, to compare intensive monitoring. So like this is getting, again, that pap smear of the vagina essentially for a vaginal cytology regularly. This is getting regular CT scans, even if people do not have any sort of symptoms. And it's getting regular lab tests, such as a CA-125 blood test, intensively and stratified by people being low risk and people being high risk. Long story short from that, that trial showed us that there was no major clinical differences with a minimalistic model of monitoring people after their cancer diagnosis was complete and their cancer treatment was complete compared to an intensive monitoring strategy. But the asterisk to some of this is that you'll see that that high risk category includes people who are anywhere above like a stage 1B, which is basically a cancer inside the uterus that is invading into the muscle deeply and trying to escape the muscle of the uterus, all the way to like someone with a stage 3 or stage 4 cancer diagnosis. And we know that this is actually a very different group of people. And so right now, what they've recommended is that for low risk patients, so patients who are early stage 1, stage 2, they can receive exams every 6 or 12 months for a couple of years, and then space those exams to every 12 months for the next 3 to 5 years. And lab tests with monitoring with a CA-125 blood test, if it's elevated, if it was high at the time of diagnosis. And then for patients who are considered high risk, and again, these risks are based on like the risk of recurrence, what we think are cancers that could come back, and we're a little bit more concerned about them coming back. So more advanced stages, so advanced stage 3 to 4. There are different types of uterine cancers. Everybody who's on this call, who I'm privileged enough to take care of in the clinical standpoint, as I've had this conversation, there are different types of uterine cancers. There's kind of the low risk types underneath the microscope and high risk types. And so any high risk type kind of counts as this as well, including patients with what's called a P53 mutation. And these folks are supposed to get really frequent exams, so every 3 to 6 months for a couple of years, then every 6 months for 3 to 5 years, and then recommended to get a CT scan for 2 years, once a year as follows, and then as indicated every 3 to 5 years. And then everybody gets a CA-125 if they're initially elevated. And then there's this concept of circulating tumor DNA, which some of you on this call I know are intimately aware of, and others might not have heard about. And I wanted to kind of go into that. I will also, and I'm going to go into that in the next slide, and I will also give the caveat of like right now, as we're in the immunotherapy space, where there are some folks that are going to be on immunotherapy for an extended period of time, months to years after their initial chemotherapy is complete. We don't really know how often we should be doing some of these studies, how often we should be doing pelvic exams and imaging scans for people who are on immunotherapy for years, because they're still kind of receiving treatment. And so the concept of surveillance when somebody is on an active treatment such as immunotherapy is very provider dependent. And so for those of you on this call who are I'm privileged enough to take care of, we might be getting regular CT scans. Maybe we're holding off on exams. Maybe we're getting CA-125s and monitoring them and doing a mix, because we tailor this individually to every patient who's on immunotherapy. Everybody's a little bit different in the reasons for their being on that therapy. And so this is very much a nebulous space. Even with these guidelines, everybody does a little bit different management in this space, but these are kind of, just so everybody on this call is aware, this is technically what's been laid out in the 2026 guidelines, and just leaving that there. Does anyone have questions about these kind of guidelines or what's been published in this area?
Really quick, Charlotte,
Yeah,
how do they do new guidelines every year?
good question. No is my answer,
Mhm.
but it varies. So there are so these are guidelines for surveillance for what should, how we should keep a track of folk or monitor people for cancer recurrences after their initial treatment is complete. And the guidelines prior to this were in 2019, 2018, 2017, 2016. Like it was like a solid 8 years, like it's been a long time since they were updated. Um, and so no, these do not come out every year. The guidelines that are used to be able to determine management of people on active treatment, those are regularly and routinely updated from a physician standpoint, like every several like months, every like 3 to 4 months. Those management guidelines, like these are the new therapies, these are the new drugs, this is how to give them, et cetera, et cetera. Those are routinely updated, but the surveillance guidelines take some time.
My question is I have two questions. One for the C125 blood test. If
Yeah.
you didn't get one initially done before you had surgery, and this, I'll put it in the chat.
Okay.
Okay. I think you might have been, I'll let you finish put in the chat. You might have been alluding to like, if I didn't have a C125 when I was diagnosed, what am I supposed to do afterwards? We run into this problem frequently.
Yes,
What I personally do in my own practice is for certain high risk
yes,
subtypes,
that's
such
correct.
as uterine serous cancer or a P53 mutated cancer, carcinosarcomas, and those are the patients where I will actually get a CA125 after surgery and kind of see what it does. I'll monitor it for a little bit. Um, and uh, and I for certain subtypes I will continue to monitor that, even not knowing what it initially was prior to surgery. That is my own practice. And so there are no guidelines in that world, like what to do if. So it's a good question to ask your own doctor, and specifically if you have a uterine serous cancer, the C125 can, I think, actually be valuable even if you don't know what it was when you were initially diagnosed.
Okay, thank you. And I'm going to ask my second one, and hopefully I don't break up on this one. Um, I like that there are some guidelines for after you've been diagnosed, but is there anything that's going to be done for particularly postmenopausal women? Because most doctors say if you have bleeding, we know that we need to have checkups for mammograms, for breast cancer. We know about cervix cancer. How do we get it out so women know about endometrial cancer, since it is now the fourth leading cause of death in women?
Yeah. Well, I think I don't want to speak for anyone else on this call, but I think that's part of the goal of ECANA is to raise awareness of the prevalence of endometrial cancer and the mortality of it, specifically for us as Black women. And I think there is, and so I'll let ECANA leadership take that question a little bit. But from a physician standpoint, I think there's a huge amount of educational awareness that's needed for providers, because one of the stories that I've heard in some of my own research interviewing patients with a diagnosis of endometrial cancer is like, I didn't even know this cancer existed prior to being diagnosed with it. Nobody talked. I thought my bleeding was normal. I thought my period had just come back, et cetera, et cetera. And when I went to my doctor to explain this, I was told, oh, they didn't have availability for several months, or the nurse practitioner I saw said, oh, let's get an ultrasound, and nobody ever followed up with me. And it wasn't met with the level of seriousness that it should have been met with. And so I think there's a tremendous amount of education that's needed from a doctor standpoint as well. Are there guidelines about the management of abnormal uterine bleeding? there are. Are they practiced how they should be practiced? No.
Yeah, that was spark question also. Were there any heat measures in place, like for mammograms and men get prostate, exam? Uh, and like the only reason I found out is because I had abnormal uterine bleeding after menopause. So why aren't we testing? Doing an ultrasound uh, as part of a HEDIS measure for for endometrial cancer.
Yeah, that's a great question in terms of uh, basically like why aren't we screening for it? 2 points to that. One, there is no screening test that has been shown to catch the cancer early. So this is an area of active research with researchers looking at like vaginal cytology. If you bring folks in and do almost like a kind of like a vaginal pap smear, but a different type, can you catch cancer early? Folks have looked at the role of doing like a not I wouldn't say a biopsy, but almost like a little bit of a more internal test to see if you can catch cancer cells early. Folks have looked at, and I'll get into this in the next couple slides. Can you do a blood test, a liquid biopsy to catch circulating cancer cells in the bloodstream? And this is an area of active research to be able to kind of develop a screening test for endometrial cancer. Why has it taken this long for us to develop a screening test for endometrial cancer is the second part of maybe that question. And the answer to that is America. America. Endometrial cancer used to not be as deadly, used to not be as frequent. And part of that is a lot of people used to get hysterectomies. A lot of our mothers and our grandmothers' generation, they had a hysterectomy because of whatever reason. They had heavy bleeding, they had a hysterectomy, right? And so as the medical field tried to move away from doing all these surgical interventions, and more minimalistic, people are growing up with their uteri, and so there's having a uterus is a risk factor for having endometrial cancer. Women's health, as we know, is underfunded in this country, and so like reacting to a growing women's health issue and concern takes years, as opposed to something that may affect men, and then something that affects particularly Black women, which this cancer has been overtaking, and ovarian cancer by leaps and bounds in terms of death rates and incidence rates for Black women since, I think Dr. Dole likes to reference, like 2003, 2005. We've been dying more from this cancer as compared to ovarian cancer that gets a lot more research funding. Again, it's a little bit of a microcosm of living in America. So know that there's active like investigation of like cancer screening strategies for how to be able to better screen for this cancer. They are nowhere near to prime time. One of my big kind of passions and research studies right now is trying to raise community awareness and be able to get navigating systems so that when you call with a recognition of abnormal bleeding, you're just connected to a doctor and don't have to kind of go through a lot of the hoops. But it's definitely an area that needs a lot of attention.
Yes, because I had it my vaginal bleeding one day, and I called my doctor, my OBGYN. They got me in the next day. They scheduled the ultrasound, and then from there I had the biopsy and the hysterectomy. So it was pretty quick for me. Um, uh, my doctors were pretty much on it.
Good. That's awesome. And that's amazing and really, really good to hear. You've got a good team.
I'm going to ask a few questions that came in the chat. So
Oh, yeah. Sorry.
yeah,
Thank you.
no problem. No, I'm going to moderate the chat for you. Don't worry.
Okay, great.
So a couple of questions. I think Dee has a couple of questions around CA25.
Okay.
One, if it raises continuously, is this a red flag? And also, can you kind of explain why the CA-125 may fluctuate?
So yeah, a consistently rising trend of a CA-125 is a red flag. That is concerning. In somebody with a cancer diagnosis, specifically like a uterine serous cancer, CA-125 as a lab test, I tell folks, is a marker of inflammation overall of the inside lining of the belly. And so that oftentimes from a cancer perspective is where cancer can grow and proliferate or become larger. And so that is why it can be elevated or high at the time when it's diagnosed, and why a consistently increased going up trend of that number can be worrisome. However, because it's a marker of inflammation, it can be affected by various things, right? I've actually seen somebody with a common cold have have their CA-125 be higher than it was at baseline. So anything that causes inflammation, like a bout of, some of my patients have what's called colitis, inflammation of the colon. Or diverticulitis, like a infection of the colon, and that will make your CA-125 high. And so it can fluctuate up and down, but what I tell folks is really important is looking at the trend. Is it consistently going up? Is it consistently going down? And those are really important.
Perfect. Thank you so much. That was a great answer. I'm so excited that you're here. I really am. My next question that I have, and I'm not sure if you're going to speak about this a little later in your presentation, so if you are, you can hold it. But can you explain biomarkers and HER2?
Yeah, we can chat about that.
I blame RG.
Yeah, that's a good, it's a good question. It's a complicated answer. There are many ways to do it. Okay, I'm going to put that in the parking lot. Let's finish the questions, and then I'm going to figure out a way to organize that in my mind.
No, organizing your mind. That was the last question that I had in the chat.
Okay, great.
Thank you. You're all asking very good questions. Again, I'm Tiffany. Okay. I'm sorry I'm so late, but please feel free to put your questions in the chat if you don't want to come off mute or you can't. So continue.
Okay. I'm gonna weave that into the next two slides, the biomarker question. Yeah. So all amazing questions. Okay, so this circulating tumor DNA, I think, is an area that folks should be aware of. And these are questions you should, things to think about and when talking with your physician team. Circulating tumor DNA is sometimes what's called like a liquid biopsy. What this is it's a blood test that kind of looks for cancer cell DNA in the bloodstream. And it's a new test, meaning like we really haven't been using it very much, or is really developed over the past, honestly, 3 to 4 years, which is very, very brand new in the cancer space. It's used a lot more frequently in the colorectal cancer space, and colon cancer. Teams have been using it for a lot bit longer than within gynecology and gynecologic cancer. And how they've used it in the colon cancer space is looking at when folks complete their initial treatment with their surgery or their radiation or their chemotherapy, if that level is, if the circulating tumor DNA is normal and not identified, or what it's called like a negative value, if it's absent, that's associated with a good prognosis. Like there's no cancer DNA in your bloodstream at all, ever undetectable, is associated with a long remission of cancer, as compared to somebody who completes that upfront treatment and they still have positive cancer DNA cells that are in their bloodstream. That's, again, a bloodstream taken from like a peripheral blood draw, or like in your arm or in your elbow area. It can also be used to monitor folks throughout their treatment, to see, again, similar to a little bit of a CA-125 level, to see if those cancer levels are going down. And that can be helpful for folks who have advanced cancer at the start. Not maybe super helpful for people who have stage 1 cancer or cancer confined to the uterus, because generally their levels might actually be negative even when they have cancer inside the uterus, because it's not in their bloodstream. It hasn't escaped. And so to monitor during therapy while somebody's getting treatment, and then using it for a cancer return. So this sometimes can be paired with, as my prior slide said, circulating tumor DNA in select cases alongside a C125 test can sometimes be used to monitor to see if cancer is coming back. But it's a very hard test to fully interpret, and we don't know or have data to say, and this is what I ask the companies that come and talk to us all the time about this test. If I catch a cancer sooner, if it comes back, and I start somebody on treatment sooner, does that mean they live for longer? Or does that mean that they just get more treatment? And we, from data from the ovarian cancer space, we actually know that the latter is true, that it actually, like, catching a cancer relapse sooner, in fact, doesn't translate into longer life. And so that is a question that is completely unanswered by the research that we have, that folks are working on right now to be able to understand the role of a circulating tumor DNA test or a liquid biopsy in monitoring for cancer recurrence. This is where it's going to dovetail into I think Margie's question about the biomarkers. So on the right side of the screen, you can see that for early stage endometrial cancer, maybe there's a role for the circulating tumor DNA to help in early diagnosis, understand kind of the role for like residual, if you still have cancer after the surgery, if it predicts if you're going to relapse and early identification of recurrence. And then on the left side, again, in the role of like advanced metastatic cancer that spread other places, I think this can actually have a little bit more of a role. And point number 3, identification of therapeutic targets, is where it ends up dovetailing with Margie's question about biomarkers. So biomarkers, and again, I don't have a slide on this, so I'm going to just kind of talk off the cuff for a little bit. Biomarkers are a way of understanding and categorizing what the molecular biology of the cancer cells are. So previously, we used to think of like low risk, high risk types of uterine cancer based on what underneath the microscope the cells look like. Biomarkers are a way to understand or tag kind of how the cancer behaves molecularly, almost understanding the DNA of the cancer and being able to categorize low risk, high risk based on the molecular features and activity of the cancer, which is parallel to, but a little bit different from how we used to kind of traditionally think of what kind of cancers look like underneath the microscope. With like, oh, this looks really bad underneath the microscope. The cell looks really disorganized. This is a bad, aggressive cancer underneath the microscope, as opposed to, oh, this is still a cancer, but the cells are organized and normal appearing. The biomarkers and molecular features are like, let's look at the DNA of this cancer, low risk and high risk, and figure out what the DNA is trying to tell us. And so the role of liquid biopsy in this setting can actually be helpful, because it tells you not only kind of presence or absence of cancer cells circulating in the bloodstream, but can also tell you the cancer cells that we see circulating the bloodstream. Here's the genetic code of that cancer. And that can now be helpful to target with new drugs. Oh, they have this type of molecular DNA of their cancer, I'm going to give them this drug. They have this molecular DNA of their cancer, I'm going to put them on this clinical trial. They have this molecular DNA of their cancer, oh, they're actually going to do so great, I'm just going to give them a little bit of radiation therapy, or they don't even need chemotherapy at all. And so it's those biomarkers can be pulled from these liquid DNAs. And by the way, what we do right now, without this necessarily these liquid biopsies, is we're doing that molecular coding of the cancer on the hysterectomy specimen, or sometimes the biopsy that's done to diagnose somebody with a cancer. Those molecular tests generally, at least, and definitely in my practice and the practice through MedStar Health, we're sending out that cancer tissue to get that molecular genetics at the start. But it can sometimes be helpful if we're monitoring somebody for a cancer recurrence, to be able to understand what their genetic code is through these liquid biopsies. Did that answer, Margie, your question at all?
Yes.
Okay.
I have read and I have listened and I have read, and each time I do it, I seem to get a piece of that and then I don't get the other piece. So that was really good. And while I'm listening to you, I'm like, that's our next webinar.
Okay. Yeah.
Biomarkers with show, because this could be like its own conversation with the Q&A. But yes, thank you. And I think I understand it a little bit better now.
Okay.
Thank you.
I have another question that came in the chat.
Yes.
Does carcinosarcoma indicate the molecular structure?
Great
some science buffs in here. I love it.
I love it. I'm obsessed. I love it. The answer to that is no. So carcinosarcoma is a type of uterine cancer, and it's defined by it's a type of classically what's called a high risk type of uterine or endometrial cancer, because these cancers can be aggressive, meaning that sometimes they don't respond amazingly to chemotherapy. The remission, you can get someone to remission, but sometimes their cancers come back sooner and they've been a little bit harder to treat. And the carcinosarcoma word is derived from what the pathology doctor sees when they look underneath the microscope. And they see some cancer cells that look like carcinoma cancer cells, and they see some cancer cells that look like sarcoma cancer cells. And a tumor that has mixed carcinosarcoma is a carcinosarcoma, different than a uterine serous cancer, which has another type of cancer cells that look entirely different from the carcinosarcomas. So it's carcinosarcoma and uterine serous and endometrioid and all of these things. That is what the pathology doctor sees when they look underneath the microscope. What we now understand in 2026, based on studies that were done back in like the 2010 era, was that the genetic code and the molecular biology of these different types of cancers are totally different and don't necessarily always align with what the pathology doctor has seen underneath the microscope. And so there have been some studies, some big trials, again, out of Europe, looking at kind of what treatments are best for patients when they're diagnosed with a more advanced stage uterine cancer. Like, should we give radiation and chemotherapy or just radiation alone? Should we give only chemotherapy compared to nothing and things like that? And they found that in these trials, when they went back and recoded everybody based on kind of the molecular DNA as opposed to the like underneath the microscope view, that the patients, even if they had what looked like a really aggressive underneath the microscope, if they had a very rare but like notable molecular thing called POLE, P-O-L-E, if their tumor had that molecular code, they had an amazing prognosis. It didn't matter that they had the gnarliest tumor underneath the microscope. They did so great. And for the people that had a pretty nice, like non-aggressive looking tumor underneath the microscope, if they had a molecular signature that was a P53 molecular signature, the DNA of the cancer had a P53 mutation, they didn't do so well. They did pretty poorly in terms of their cancer recurrence and things like that. And so I gave you a long answer, but the take-home message from that is like, there are some differences subtly with like what things look like underneath the microscope and what their genetic code is. And everyone on this call should know not only the name of their cancer, a serous, a carcinosarcoma, an endometrioid, a clear cell, but also a little bit about the genetic code of their cancer. Is it a P53 mutated cancer? Is it a mismatch repair deficient cancer with like the Lynch syndrome proteins have been tested? is there a POLE mutation, spelled like the word pole, POLE, mutation associated with that cancer? So you should not, I used to say, know what type of cancer you had. And it's not only just the type of endometrial cancer, but the genetic code of the endometrial cancer that's really important to understand, because that helps drive understanding the risk of the cancer ever coming back and the types of therapies that you should get in the future.
Hi, this is Patricia's daughter right here, but she's right here. She got diagnosed with endometrial clear cell.
Okay.
Can you kind of explain what clear cell is? Because we're just starting our education on this cancer journey.
Yeah, of course. So clear cell endometrial cancer is a type of endometrial cancer that is, again, historically been in the high risk type of category of uterine cancers, meaning it's more aggressive, it spreads a little bit faster, it's a little bit more difficult to treat. Classically, clear cell endometrial cancers have this P53 mutation. So when we talk about underneath the microscope, it's clear cell uterine cancer. The cells have a very specific appearance, and so that's what gives that diagnosis. When we look at the genetic code of those cancers, quite often they are associated with this P53 mutation that is associated with a aggressive kind of cancer overall. Management for this cancer includes a hysterectomy to start with lymph node sampling, and then oftentimes chemotherapy. What can sometimes be a challenge with clear cell is that it might not be super responsive to chemotherapy in the same way that, let's say, a uterine serous cancer, which is also P53 mutated high-risk cancer, can respond to chemotherapy. So clear cell ends up being a bit of a challenging diagnosis for both, obviously, patients that carry the diagnosis as well as the clinicians that care for them. And so it's really important to understand the molecular code of the cancer. It's really important to understand the clinical trials that someone can be enrolled on, and be able to understand kind of options to help manage and decrease the risk of the cancer ever coming back.
Okay, all right. And with this type, they said that they didn't think that she was a candidate for radiation. Radiation doesn't help that?
Yeah, it's not really radiation sensitive, meaning like you can give radiation to it, but clear cell will stick around even if the radiation is given. And so sometimes it's like the thought is the risk benefits, like I'm going to give you all this treatment, give you these side effects of the radiation therapy, and I don't really think it's going to work. And so that's what makes it a little bit challenging.
Well, do you know of my last question? Do you know of what has worked, or have they found anything that has worked besides the chemo? Or
Great question. With clear cell, actually, there's some data that shows immunotherapies can be particularly helpful. So immunotherapies, for whatever reason, it's like it doesn't make sense to like the doctor brain fully, because we usually say immunotherapies can help kind of maintain the benefits of chemotherapy. But truly immunotherapy can help fully treat it. And for clear cell cancers in general, ovarian clear cell, endometrial clear cell, immunotherapy has sometimes really worked, like pembrolizumab, dostarlimab immunotherapy.
Okay, great. Thank you for answering all the questions.
Yeah, for sure.
Awesome. All right.
These are all such good questions. I've like finally opened the chat.
I know. Don't worry. I'm writing them all down, so you can keep going, but I have them all.
Yeah. Okay, great. I will answer Miss Amanda's question, the difference between adenomyosis and adenocarcinoma. Adenomyosis is a benign condition of the uterus where there are glandular cells of the uterus that find themselves in the muscle of the uterus, classically associated with like heavy menstrual cycles that are generally non-painful, and an enlarged uterus. So it's benign, non-cancer, heavy periods, and the uterus looks like there's a unique appearance that it has in like an ultrasound. Adenocarcinoma, cancer. So this is a type of cancer. There are many different types of adenocarcinoma. Adeno just says it's a glandular cancer. So you can have a cervical adenocarcinoma, you can have an endometrial adenocarcinoma, you could have a pancreatic adenocarcinoma, you could have any name your organ adenocarcinoma, but that's a cancer term. And then I answered clear cell carcinoma, endometrioid versus non-endometrioid. I'll answer Sophia's question and then I'll just bop to the rest of the chat. Again, they're non-endometrioid are classically high risk aggressive types. Endometrioid is classically low risk non-aggressive types, but within that there's the huge asterisk of know the molecular subtype of the cancer and the molecular genetic code of the cancer. We are finding more and more that is actually what's driving cancer recurrence, and is very, very important to help patients and their doctors figure out what is a targeted therapy for that cancer type if it ever comes back. This is a diagram that shows like future roles for this liquid biopsy that we have not yet explored, that there's active research going on. When you get it preoperatively, and if it's positive preoperatively in somebody who we thought only their cancer was inside the uterus, but oh no, we see it now in their bloodstream, do we add more imaging? Do we do more surgery? After we've completed their treatments, do we add on extra therapy? Do we change therapy if their circulated tumor DNAs are rising? And then in the monitoring world, do we scan early? Do we change therapy sooner? These are all active questions. And so those of you guys on the call getting the circulator tumor DNA cells, the liquid biopsies done, I think it's a valuable kind of question to ask your doctor, like, how are you planning to use these tests in your management of, and as we treat this cancer and as we manage or monitor this cancer? What are your plans if my levels go from 0 to, or like undetectable to detectable? At what point would you want to get another CT scan if my levels start rising? Like, how many valleys is it going to take for you to say like, okay, now we should get a CT scan? Or are you just using this for research purposes, which is totally fine and good, because we literally have no idea in the oncology world how to use this. And so there's a role just to collect the data. But I think it's important that, like, are you getting the circulated tumor DNA cells? And if so, like, are we using it just for research collection, or are you going to use it and like change your management of my health based on that? I think is important questions to ask. And you don't have to have this. This is not within guidelines to be routinely getting, and you're not missing anything if you're not getting this. But if you are, these are questions to ask. So survivorship, these are the guidelines that are for the clinicians for survivorship. I will note that there are 323 pages of guidelines, which is insane and crazy. And I got personally very overwhelmed when I started looking at this, and I was like, this is too much. But just know that there's a lot of data and a lot of research out there, and again, on kind of the concept of survivorship and like how to best care of the whole person when we are thinking of a cancer diagnosis and managing. These are the kind of patient-facing materials, so I think much more user-friendly, some more pictures, some more diagrams that I think can be super helpful. And note that they were published back in 2024, which is kind of annoying because I think it's time to update them, but I think can be helpful and comprehensive. And they talk about anything from physical activity, food and supplements, weight metabolism, infection, treatment decisions, and then everything else with managing specific things that can be affected by cancer diagnosis, hormone-related symptoms, heart disease, lymphedema, cognitive dysfunction that can happen with chemotherapy, sexual dysfunction and sexual health, fertility, fatigue, sleep, pain, mental health, work challenges, lots of things, right? So the list is long. I'm not going to go into everything at all. And a lot of this is stuff that you already know. And so I'm going to breeze through this because, again, I want to get through this idea of like survivorship to what I think is a better term, because my patients think it's a better term. So healthy living, be physically active, do the good things, stay out of the sun, like eat healthy foods, move multiple times a week, be active every single day, do some resistance training, like move your muscles, and I think this is something that folks can sometimes realize, like, after their treatment is completed. This is really hard to do while you're currently on like chemo. Like, I think this is a really tall ask, but I will say that folks who are able to maintain a higher level of physical activity during their treatment can build better, like, kind of strength throughout their treatment and be stronger when they're all done with it. Remember when we were told by the US government that we needed to eat the food pyramid, and it was like 8 to 10 servings of like rice a day was the base of the pyramid? Like protein was somewhere halfway through. Anyway, so take this for a grain of salt. No pun intended, but this is what we should be doing right now, right? Like splitting our plates into these proportions where fruits and vegetables take up half of the plate, and then like whole grains and proteins are the other half of the plate. And we all know this, but I think realistically, like, it's very hard to sometimes do this. And maybe people, what I find in life is that people are actually doing this, and then they get a cancer diagnosis, and this plate is like thrown out the window, and you're literally just like sipping Ensure drinks as much as you can because your doctor told you that protein is the most important thing. And then as you go through it, you're trying to figure out kind of like, how do I get this plate back? And that can be really hard. And I hope everybody on this call has been connected with a nutritionist, and having a nutritionist, at least that you meet with once throughout your initial diagnosis, and maybe even circling back to that nutritionist after you've completed all that upfront therapy is really important. And that's actually an expectation for all cancer centers, to have a nutritionist that somebody is able to access and see at least once throughout their treatment. A slide on like healthy foods. We all know this, but like, again, the role of a nutritionist is not telling you like, these are the foods you should eat, but is, I think, really important to be like, how do I do this if I'm so exhausted from chemotherapy I can't even get out of bed? Or how do I do this if like chemo or radiation or surgery derailed me so far off that like all I really want to do is eat potato chips, and I like can't get myself to drink the Gatorade that you're telling me to drink, or Ensure. And so I think that, like, really, again, encouraging everybody to like talk with a nutritionist, not just what you should be doing, with which most everybody knows, you like the foods we should eat, but how to do it, and how to actually like build the habits and surround yourself with the people that are going to encourage that. Okay. I have like this second, this is what I wanted to talk about for like so much of the talk. And so this could be its own thing. I don't know. Like, we could just circle back to this.
Yeah.
This is my passion project, and I was like, I think I should write a paper on this. I think I should write a comment on this. Like, I was thinking about, as I was getting these slides together, I was like, we should do this as ECANA, really taking ownership of like Thrivership. Because I, again, was told by several, but definitely one patient that was like, I don't like this term survivorship. Like, it's not a thing for me. I don't accept that. I reject that. We're moving to Thrivership. And I was like, I recognize, I love that. Let's do that. And when you actually put it into like google.com, or in our world PubMed, of the National Library of like Medicine, there's not a lot out there on Thrivership. And actually the data on Thrivership, or the use of this term, comes from domestic violence literature, where I often will talk to my patients about having a cancer diagnosis is a form of trauma. And going through surgery, chemo, radiation, immunotherapy, whatever else is complications, is a form of trauma. And naming that and recognizing that trauma is real, and it takes it takes a lot out of you. And so there's so many, when I started thinking about like this term and seeing how it's been used in the literature, and it coming from domestic violence literature, it also brings to light like recognizing and naming the trauma that we experience through this diagnosis that we have, right? And how to like recognize that, accept that, to be able to move past it. I don't think you ever move past a trauma, but like get your life a little bit kind of what you want it to be, I think is a whole process. And I think there's a lot that we have to learn in the cancer sphere from like domestic violence. Anyway, I think we should write something about this, because I think there's something to be seen here. Because I do think that, like, what I underlined here, like the fact that like thrivership is like a process where you're moving, it's active, it's fluid, it's non-linear, it's a journey, even though I think that term is way overused in the cancer sphere, of like self-discovery and like recognizing and re-embracing who you are. And these traumas like, you know, cause you to fall back a couple steps or like break you all the way down to like, who am I? Like, what is important to me? Like, what is my purpose? And one of the reasons why I just am so privileged to be in this work is because it always is a reminder to me, like to, you know, stop and just the gratitude, right? Of giving that perspective. This is an image from one of the domestic violence papers about like how these three components are really important to like get through that process of thrivership. Like, are you safe? Are you safe in your day-to-day world? And that's not physical safety, but that's like emotional safety. Are you surrounded by people that make you feel safe in your diagnosis? Can you share your story? And that's where I think ECANA is so just, love it. Can you share your story? Is there a place where you can share your story and gain some of that empowerment to share your story? And when you share your story, are you met with like a positive response from providers, from other individuals? And these three components being really important to get to that thriving, where you're able to kind of not only accept that diagnosis, but have a positive outlook. This is like a little diagram that was published from a patient advocate who is a neuroendocrine type of a tumor that was just shared at there's like a national cancer meeting that happened recently in April that I thought was a nice diagram of like the different components to Thrivership. And I think is kind of important to think about these different components. But I also think that, like, again, these are the questions that I think are important to ask at any point in somebody's process, right? When you're initially diagnosed, as you're going through your treatment, as you complete your treatment, and like every so often thereafter, like, what are your values? What is like super important to you in your life? What makes you happy? What brings you joy? Where do you find meaning and purpose? And is there a role for it? And these are things that I, again, found from the domestic violence literature. Forgiveness. Is there anybody that you have to forgive in your cancer diagnosis? Do you need to forgive yourself? An acceptance. And what does that mean? And then I think really important is like the role of faith and spirituality and how that can play a role if that's something that is meaningful to you as an act of reclaiming that agency. So that's my last slide. I blew through those ones, but like, that's kind of where I want to leave it. Food for thought. We had a biology class today, but also like a little bit of like, I think the psychology of this is really, really, really important.
So Diane, first, Diane, I know you're in the room. I don't know if you want to talk about what you just shared in the chat, but I'll just share really quickly that she shared that she doesn't like to share certain information with her doctor. Their next step is always to seem to be mental therapy of some type. And I am speaking strictly as a patient advocate and as a caregiver to someone who had endometrial cancer. And again, Dr. Gamble, please feel free to chime in. I want you to share everything with your healthcare providers, even if the answer that you get is not something that you want. I want you to be able to be 100% transparent, because what I want for you is that they're 100% transparent with you, right? And so if you don't tell them certain information, you may not get information that you can discern and make your own informed decisions about whether it's right for you or not. That's just me personally, but Dr. Gamble, you can take that comment because I feel like it's important. Just in terms of how you communicate with your healthcare provider and what that looks like for you when you're speaking with your patients who may be afraid to talk to you.
Yeah. I think this question gets down to the kind of like being vulnerable and like how to express that vulnerability to the doctors. And I mean, being vulnerable is a complex term for us as Black women. Like, I don't, that's not, it's a hard thing for me to do. So it's like, I think it's very hard to do. And in this day and age with like these 15-minute visits that, from a physician standpoint, it's really hard to sometimes hold that space for patients to feel safe. So it gets back to like, are you safe? You can be vulnerable. You have the time to be vulnerable with your doctor. Are you safe with that doctor? Is that doctor responding to your vulnerability? Do you feel dismissed by them because they say, okay, like, sounds like you're going through a hard time, you should talk to a psychologist, and you're like, no, but I want you to, like, right? Is there a version where you need to, is there another person in that care team that you feel more safe with? Like, is there a nurse navigator, or a medical assistant, or the oncology nurse that hangs your infusion that you could be vulnerable with this group, right? So finding a place where you feel safe, I think, is really important. If you don't feel safe specifically with a physician, then that's a little bit concerning. And like, do you need to transfer your care? It feels really overwhelming, but that's sometimes like what you got to do. Because you can get really good care, but if you really can't deal with the personality of the person that's in charge of your care, then that might not work well. So yeah, that's what I'd say. I personally, I want to make sure that in my practice, everybody is able to ask me any sort of questions. And so I really try to make sure that it's I emphasize a judgment-free zone, et cetera, et cetera. Sometimes logistically, in the context of these visits, like, we run out of time. Not time. We're like, hey, did you have a neuropathy? Are you walking? Are you eating? Like, did you have issues with transportation getting to chemo? Like, did you have a reaction, right? And so there's maybe not the time to express, like, I'm emotionally having a really, really rough time with that. But it might be one of those things that if you have a physician or a care team that you feel like can listen to and hear you, either exploring, like, is there someone aside from the doctor that I can share these things with that would support me, and then transfer my concerns to the doctor? Or can I say, like, hey, Dr. Danu, like, I'm really having a hard time. Can we maybe set some time aside at our next visit for me to share this with you and really prioritize that? And the medical stuff I'm doing fine with, but can we spend the next time at our visit talking about that and seeing if that can be a helpful approach?
Thank you.
Just want to say I have a team. When I was first diagnosed, they gave me a whole pamphlet of resources, even down to financial help if I need help. I wish all of us had that type of resources available. I even have a nutritionist. I mean, it's a whole collaborative team. My internal medicine doctor is not with that practice, but she made sure that she was included in my treatment. She called the oncologist and made sure that she was included in everything because my the chemo and the immunotherapy really affected me bad, and uh they work together, and because I started stuttering with all this treatment and a lot of brain fatigue, so I do see mental health and speech therapy, physical therapy, and occupational therapy to help me. I'm sorry. That's it, through all of it. It's a lot.
Yeah.
It's a whole lot.
Yes,
Mm-hmm.
it is. Thank you, Terry, for being so transparent. Appreciate that. Yep, it's a lot.
Been an honor, a privilege to
Mm.
share this space with you again. I am just I'm just really lucky, and so thank you for allowing me to share some thoughts this morning and being so receptive
Mm.
and so vulnerable. And
Yeah.
feel free to reach out with any questions, and Margie knows how to get hold of me. So thanks,
You
everybody.
bet.
I'll let
You
you guys
guys,
get the space back. Thank you so much.
yes,
Thank
no,
you.
thank you.
Okay.